Hello, we are Group 12 and we will be presenting ankle sprain.
Venus for anatomy and kinesiology. So the ankle and foot complex, so it has 28 bones and it forms 25 joints. So that would be your talocrural joint, talocalcaneal, talonavicular, and calcaneocuboid joints or the transverse tarsal. Tapos yung tarsometatarsal, metatarsophalangeal, and interphalangeal joints. So divided siya into three segments. So yung hindfoot, midfoot, and forefoot. So yung hindfoot, composed siya ng talus and calcaneus, and then the midfoot, which is the navicular, cuboid, and triconiform. And then yung anterior naman is your metatarsals and phalanges. Okay? Next slide. So the talocrural joint or the ankle joint, so articulation between the distal tibia and the fibula proximally and the body of the talus distally. So it's a synovial hinge joint, so meron siyang joint capsule and it has a single oblique axis and 1 degree of freedom. Tapos dorsiflexion and for dorsiflexion and plantar flexion. Dorsiflexion would be its close packed position while slight plantar flexion naman yung open pack niya. It is most commonly injured in sports. So when you say proximal ankle, you are referring to the concave surface of the distal tibia and the lateral and medial malleolus. Tapos mortis naman would be your distal tibia and the two malleoli, which is which changes and adjustable depende sa proximal and distal tibiofibular joints. Okay? And then, next slide. So, your proximal tibiofibular joint is the forgotten joint and it is the articulation between the head of the fibula and the posterior lateral aspect of the tibia. Surrounded siya by by a capsule which is supported by the anterior and posterior tibiofibular ligaments. Kaya siya forgotten joint kasi it is incorrectly associated with the knee. Your distal tibiofibular joint naman, it's a false joint. So, fibrous connection between the concave facet of the tibia and the convex facet of the fibula. Hindi sila in contact with each other kasi mayroong fibroadipose tissue in between. Then, ligaments also help in stabilizing this joint. So, yun yung anterior and posterior tibiofibular and the interosseous membrane. Sila yung nag-give ng support. So, it's an extremely strong joint. However, pag na-injure pa rin naman siya. Pag na-injure, it is called your high or syndesmotic ankle sprain when the fibula and tibia separate. Pag nag-continue pa yung force na yon, it may cause fracture of the fibula close to the distal tibiofibular ligament. Okay, so yung next slide. Transverse tarsal joint naman, it is also called your mid-tarsal, Chapards, or surgeon's joint. Formed siya by talonavicular and calcaneocuboid joint. So, adduction and abduction naman dito. The proximal portion of the talonavicular joint, so yun yung anterior head of the talus and distal connection by the concave posterior aspect of the navicular bone. Next slide. So, merong joint capsule that encompasses the joint facets and the anterior and medial facets of the subtalar joint. So, we have your plantar calcaneal navicular ligament or your spring ligament. So, this spring ligament forms the inferior aspect of the joint capsule. It is from the gap between the calcaneus and the navicular, which is right below the talar head. So, the one that reinforces the capsule medially would be your deltoid ligament and the bifurcate ligaments naman for the lateral. So, this spring ligament is a ligamentous connective tissue that is from the sustentaculum tali, which is from the calcaneus and nag-insert siya sa inferior navicular bone. It is continued medially with the part of the deltoid ligament of the ankle. It connects laterally with the bifurcates ligaments medial band. Tapos, yung spring ligament na to, meron siyang superior medial, medial plantar oblique, and inferior plantar longitudinal bands. Meron siyang special rule in supporting the talonavicular joint and the head of the talus, and it also functions as one of the main passive stabilizers of the medial longitudinal arc, so that maintains it. Aside from the spring and bifurcate ligaments, there's also the dorsal talonavicular ligament that supports the joint. Next slide. So, yung calcaneocuboid naman, so anterior calcaneus proximally and posterior cuboid bone. So, concave siya on both sides. So, that's top and bottom. So, the movement is more restricted here compared sa ball and socket shape na talonavicular joint. So, involved siya in weight bearing to the subtalar joint, just like the talonavicular joint. So, Yon. During weight-bearing activities, the calcaneus moves at the subtalar joint and it should meet the conflicting intra-articular demands of the opposing saddle-shaped areas which results into a twisting motion. Okay, so pag yun. So this joint also has its own capsule which is supported by other ligaments. Next slide. So laterally, yung lateral band of the bifurcate ligament. So dorsal naman would be your dorsal calcaneocuboid ligament. Tapos sa inferiorly, andun yung plantar calcaneocuboid or your short plantar ligament and the long plantar ligament. Yung long plantar ligament is the most important ligament kasi it spans the whole calcaneus and cuboid bone. Tapos, continue distally to the bases of the second to the fourth metatarsals and it supports the transverse tarsal joint and the lateral longitudinal arc of the foot. Yung transverse tarsal joint is also reinforced by the extrinsic muscles of the foot as it passes through the medial and lateral and inferior to the joint. Next slide. So, this one, the subtalar joint, it has various articulating surfaces. Pero yung biggest articulation would be between the talus and the calcaneus. Okay, so it's a stable joint, the strong support from ligamentous structures. So, yung posterior articulation niya would be concave facet on the undersurface of the talus and convex facet on the body of the calcaneus. Tapos, pag anterior and medial naman, two convex facets on the inferior body and neck of the talus and two concave facets on the calcaneus. So, yung inversion and inversion daw dito, it doesn't happen in just one plane. There is a complex twisting or screw-like motion that occurs. Okay, so there is also a bony tunnel made by the sulcus in the superior calcaneus and inferior talus. This one is the tarsal canal, tapos funnel shape siya. It runs obliquely across the foot. Okay, so the large end is called the sinus tarsi, which is the proprioceptive center or the eye of the foot. So, meron ding neurovascular structures doon, and the small end is called the sustentaculum tali. Okay, so, next slide please. Okay, so, meron din siyang passive stabilizers that supports the ankle and those that only cross the subtalar joint. So, yung lateral support niya would be calcaneofibular, lateral talocalcaneal, cervical, and interosseous talocalcaneal ligaments. Yung cervical ligament, it's the strongest ligament that lies in front of the sinus tarsi and it joins the neck of the talus until the neck of the calcaneus, hence cervical ligament. The interosseous talocalcaneal ligament is found more medially within the tarsal canal. Next slide. Okay, tarsal-metatarsal naman, articulation siya with the tarsal and metatarsal, okay? So, the first TMT, it articulates with the medial cuneiform, meron siyang own capsule. Yung second and third, they share a joint capsule, just like the fourth and fifth. Yung second, it articulates with the middle cuneiform, tapos yung third with the lateral cuneiform naman. So, just like what I said, yung fourth and fifth, they share a capsule. Tapos sila naman yung may articulation with the cuboid bone. Tapos, next slide. Supination twist. So, during hindfoot pronation, the medial forefoot will press into the ground and the lateral side will lift and the first and second ray dorsiflex while the fourth and fifth plantar flex in order to maintain the foot contact on the ground and the entire foot undergoes inversion rotation. So, pronation twist, opposite lang nun. So, the hindfoot and transverse tarsal joint locked in supination naman, the medial forefoot will lift and the lateral side will press into the group while the first and second raise plantar flex and the fourth and fifth dorsiflex. Okay, next slide. So, metatarsophalangeal joint. So, convex metatarsals and concave phalanges. Meron siyang 2 degrees of freedom for flexion, extension, abduction, adduction. Metatarsal break is your MTP extension during walking. Then you have your interphalangeal joints that are synovial hinge joints. They have 1 degree of freedom for flexion and extension. Next slide. So, the composite motion naman, pag non-weight bearing. So, pag supination, you have calcaneal adduction, inversion, and plantar flexion. So, for pronation, it's just the reverse of that. So, meron kang abduction, eversion, and dorsiflexion ng calcaneus. The composite motions naman, pag weight bearing, supination would be calcaneal inversion, talar abduction, talar dorsiflexion, tibiofibular lateral rotation. And then, again, just the reverse for weight-bearing top na pronation. Next slide. So, here, the joint axis of the talocrural joint in the neutral position is through the lateral malleolus and body of talus, or just below the medial malleolus, kasi the lateral malleolus is farther than the medial. So, the lateral malleolus or the fibular malleolus is more distal and posterior. So, there is tibial torsion or tibiofibular torsion, which is the reason for the toe out in normal standing. The degree of freedom is for plantar flexion and dorsiflexion. So, meron din tayong inclined axis na 14 degrees pag non-weight bearing. Dorsiflexion, associated siya with eversion. Tapos, pag inversion naman, plantar flexion. Pag weight bearing na, dorsiflexion is associated with inversion and internal rotation. Tapos, pag plantar flexion, eversion and external rotation naman. Okay? Next slide. So, the joint axis of the subtalar joint has a screw-like motion. So, meron kang triplanar motion, which leads to pronation or supination. The ligaments of the talocrural joint would be your crural tibiofibular interosseous ligament, the anterior and posterior tibiofibular ligaments, the tibiofibular interosseous membrane, the medial collateral ligament, and the lateral collateral ligaments. Okay, so sila yung commonly injured. So, the lateral collateral ligament is composed of your anterior tibiofibular ligament, which is the weakest, and it restricts plantar flexion and inversion. The mechanism of injury is plantar flexion. Posterior tibiofibular ligament naman, this one is rarely torn dahil sa orientation niya, pero mechanism of injury niya would be dorsiflexion or dorsiflexion with external rotation. Calcaneofibular ligament naman, the mechanism of injury is in neutral or dorsiflexion with inversion. Your medial collateral ligament or your deltoid ligament is composed of your anterior tibiotalar, posterior tibiotalar, and your tibionavicular. Then, inversion sprain is more common than your eversion sprain because there are more ligaments on the medial compared to the lateral side, and the ligaments are also closer together, so it's stronger. And then, in your anterior, the muscles naman in the anterior compartment of your foot, that would be your tibialis anterior, which is the primary dorsiflexor, your EDL, extensor hallucis, and peroneus tertius. And then, sa posterior compartment naman, so, ito na yung plantar flexors. Your superficial ones would be the triceps surae, so that's the gastrocs and soleus, and the plantaris. While the deep plantar flexors are the FDL, and then yung flexor hallucis longus, and the tibialis posterior, which is the inverter par excellence. It is the primary invertor and deepest muscle siya. While the popliteus din, siya din yung deepest muscle behind the knee. Sa lateral, andun yung evertors and plantar flexors, which is your peroneus longus and brevis. So, sila yung nagproprotect ng lateral side naman. Okay? So, the gastroc and soleus limits dorsiflexion. Tapos, the ones that limit plantar flexion would be your tibialis anterior, extensor hallucis, and longus, and your extensor digitorum longus. Tapos, the tibialis posterior and flexor hallucis longus and flexor digitorum longus protects the medial, while like what I said earlier, the peroneus longus and brevis protects the lateral ankle. The only muscle that is found in the dorsal compartment of the foot would be your extensor digitorum brevis. So, the plantar compartment naman, so the first layer andun yung abductor hallucis, flexor digitorum brevis, abductor digiti minimi. Sa second layer andun yung lumbricals and quadratus plantae. Sa third layer andun yung flexor hallucis brevis, abductor hallucis, and flexor digiti minimi brevis. Sa fourth layer andun yung 7 na interossae. Okay. So that's it for the anatomy and kines part. Thank you.
Bago po, I will be presenting the medical surgical part. So, a sprain is defined as the severe stress, stretch, or tear of soft tissue such as joint, capsule, ligament, tendon, or muscle. So, they're usually graded as first, second, or third degree sprain, or also commonly known as mild, moderate, or severe type of sprain. So, ankle sprains are usually caused by trauma wherein the ligaments of the ankle may be stressed or torn. And the most common type of ankle sprain is usually caused by an inversion stress trauma encountered in sports that require running or jumping, such as football, tennis, basketball, soccer, and gymnastics, and can result in a partial or complete tear of the lateral ligament complex. So, the lateral ligament complex is composed of your anterior talofibular ligament or your ATFL, your calcaneofibular ligament or your CFL, and the posterior talofibular ligament. So as we can see in the video, the mechanism of injury of an inversion sprain. So as you can see from the table, there are descriptions for each of the grades of the ankle sprain. So these are all according to DLISA. So a grade 1 ankle sprain involves a mild sprain which involves the ATFL with a negative ankle drawer and tailor tilt test, while a grade 2 sprain involves disruption of the ATFL with sprain of the CFL, positive ankle drawer test and a negative tailor tilt test, while a grade 3 ankle sprain involves disruption of the lateral ligament complex wherein there may be a complete tear or rupture of the ATFL, often the CFL, and sometimes the posterior tibiofibular ligament with both positive ankle drawer and tailor tilt tests. So, tearing of the ATFL usually results from forceful inversion while the ankle is plantar flexed. And when both the ATFL and CFL is torn, combined instability of the tibiotalar and subtalar joints may occur. So, injuries that may be associated with ankle sprains are articular cartilage lesions, transverse fracture of the lateral malleolus, or an avulsion fracture of the base of the fifth metatarsal. So, ankle sprains may present with swelling, tenderness, and often pain. So, aside from these, a complete tear of one or more lateral ligaments may cause marked mechanical and functional instability of the ankle during weight bearing activities. So, mechanical instability is defined as the ankle mobility beyond the physiologic ROM, increased talar tilt, and anterior drawer sign indicative of joint laxity, while functional instability is defined as the patient sensation of the ankle giving way. Your posterior tibiofibular ligament is considered as the strongest of all the lateral ligaments and can usually be torn only by severe inversion stresses. While your inferior tibiofibular ligaments or your ITFL are torn after stress to the ankle, wherein the mortise may become unstable. So, it is uncommon that the deltoid ligaments on the medial side of the ankle become stressed and usually results from an eversion stress. Syndesmotic ankle sprains or your high ankle sprains are considered more common than deltoid ligament sprains. So they can be a source of disability, for example, in a competitive athlete, and they can also cause significantly prolonged recovery time in contrast to the isolated inversion ankle sprains. In ankle sprains, the joint capsules may also be stressed depending on the severity of the injury. According to Kistner, common impairments and functional limitations include pain when the injured tissue is stressed in mild to moderate injuries, excessive motion or instability of the related joint in the case of complete tears, proprioceptive deficit manifested as decreased ability to perceive passive motion and development of balance impairments, related joint symptoms and reflex muscle inhibition, possible decreased ROM of the talocrural joint in recurrent lateral ankle sprains due to anterior subluxation and impaired tracking of the talus in the mortise, postural control deficits following an acute lateral ankle sprain in both the injured and uninjured limb, restricted ambulation wherein there may be a requirement of an assistive device during the acute and subacute phases, and if with chronic instability, the individual may have difficulty walking or running on uneven surfaces or making quick changes in direction. He or she may also be unable to land safely when jumping or hopping, and there may be possible frequency of falls.
Rodriguez. So for the differential diagnosis, the case presented with inversion sprain. So here, inversion sprain, eversion sprain, high ankle sprain, and lateral malleolus fracture. So for the inversion sprain, the pain is in the outer or lateral foot, and the affected ligaments are the anterior talofibular ligament, calcaneofibular ligament, and the posterior talofibular ligament. For the eversion sprain, the pain is in the inner or medial foot. Affected are the anterior tibiotalar ligament, posterior tibiotalar ligament, tibio-calcaneal ligament, and the tibio-navicular ligament. And for the high ankle sprain, the pain is above the ankle, and it affects the syndesmosis ligament complex. And for the lateral malleolus fracture, the pain is in the outer lateral foot. Pain occasionally settles quickly and may be prominent at night at first thing in the morning. And patient may also experience pins and needles or numbness. And further similarities, swelling, bruising, and pain increases when standing or walking, causing difficulty in limping, and it is common among athletes. So here's a GIF to show the differences of the high ankle sprain, inversion sprain, and the eversion sprain.
So this is the subjective part of the case. So our patient AL, a 20-year-old negative hypertensive, negative diabetic, right-handed female patient was referred for PT evaluation and management due to complaints of intermittent deep nagging pain on the outer part of her right foot, graded 5 out of 10 using the subjective pain scale, 0 no pain, 10 worst possible pain, and states that pain was at 0 at rest, but with any weight bearing, the pain would increase to 5 over 10, especially during running and jumping. So her condition started a month prior to consultation while she was practicing in a practice session for her cheerleading squad. She also stated that she landed on another team member's foot during a lift maneuver. The patient rested for a few moments and continued practicing despite a tender ankle. 3 days later, the patient returned to the gym for a follow up workout and re injured the same ankle following a jump maneuver. So she recalled landing on the outside aspect of her right foot, heard a pop, and experienced severe pain graded 9 out of 10, 9 over 10. Stated that she was given ice and compression wrap by athletic trainer. The radiographs were normal, and since that incident, pain was reduced but did not disappear. So, persistence of pain prompted consultation. The patient lives in a 2-story house with 20 step stairs. The patient is a student who goes to the fourth floor of their building for her classes and regularly goes to the cheerleading practice but would often be unable to perform a lot of maneuvers due to pain, and the patient wants to practice without pain. So, as you can see here, this is the objective assessment that was found during the initial evaluation of the patient.
Chua. Inconsistencies. Negative muscle guarding on both lower X. There should be muscle guarding on the right lower X. And negative anterior drawers test. It may be because due to the swelling. Chua. Additional examinations. We should take the patient's past medical history. And does the patient smoke or drink? We want to know the pack gears and the frequency of how she drinks, like occasionally, weekly, once a week, or so on. The patient's hobbies, who does she live with, the distance required to move around her house, such as room to kitchen, room to restroom, room to stairs, and so on. And also the probe further on cheerleading practice, on how often does she practice, how long is her usual practice, specific position in cheerleading, what type of maneuvers does she usually perform, how is pain relieved, mode of transportation to and from practice. We should also check for the patient's shoe assessment and also for the patient's foot and ankle disability index, where the foot and ankle disability index is designed to assess functional limitations related to the foot and ankle conditions. The FADI is a region-specific self-report of function with two components. The FADI was first described in 1999 by Martin et al. It assesses activities of daily living, and the FADI sport assesses more difficult tasks that are essential to sports. Length of test lasts 0 to 5 minutes. And also the patient's BMI. Patient is mesomorph, so BMI should be also considered.
Aban, ICF for ankle sprain. First, let me talk about the direct impairments first. Commonly, in ankle sprain cases, there will always be a presentation of pain and swelling. In this case, there is an intermittent deep nagging pain on the right outer part of her right foot, graded 5 over 10, with accompanying swelling, grade 2 tenderness, hematoma formation, and due to its chronic nature and somewhat repetitive, there is a presence of poor dynamic balance and proprioceptive deficits on the right foot. For the indirect impairment, LOM on the right ankle, um, it's an indirect impairment because of pain and swelling, which caused the LOM of the right ankle. For the composite impairments, There is a weakness of the right dorsiflexors, plantar flexors, everters, and inverters. Since it's a composite, its cause are pain and LOM. Since it's painful, and when it's painful, you have LOM, so you won't get to move it properly. Because of those things, you can cause atrophy, which will cause weakness. Next is the gait deviations, most specifically negative heel strike on the right foot and flat foot. It's an it's a composite impairment. I'm sorry, because of the pain, swelling, and LOM. First, let we talk about why heel strike is absent. Uh, our group thought na it's because of the pain, since it's sort of like an antalgic gait, where the patient doesn't want to dorsiflex his ankle. And next, weakness, because there is also a presence of weakness. For the flat foot, the weakness of the foot muscles can cause flat foot. And the weakness is caused by pain and LOM. So it's a composite. And for incidental findings, positive crepitations on the bilateral knees and negative tightness of the bilateral heel cord and outtowing of the right foot.
For activity limitations, the patient presented with no activity limitations. She was independent in bed move, transfers, sit-to-stands, and basic ADLs. She has normal sitting-standing tolerance and static balance. For participation restriction, there is difficulty in returning to practice for cheerleading. For environmental factors, the patient lives in a two-story house with approximately 20 stair steps and classes at the fourth floor. These are considered factors because there is repeated use of the right foot, which could lead to reoccurrence of the ankle sprain, especially going up and down flights of stairs. For personal factors, her being a cheerleader is considered a factor because there are stressful and provocative movements done in cheerleading that could also lead to an ankle sprain.
Conde for assessment. Diagnosis would be a PT diagnosis with PT impression of right subacute recurrent inversion ankle sprain, further defined by inability to do cheerleading maneuvers such as jumping, secondary to fair dynamics balance, pain, swelling, LOM weakness, proprioceptive deficit, and gait deviation. For the intervention scenario, it would be primary restore and secondary prevent. Primary restore because the impairments can be addressed by physical therapy interventions, and then secondary prevent because the patient is an athlete and her sport involves maneuvers that is prone to injury. And then the prognosis of the patient would be good because she's an athlete and most likely she will adhere to her intervention and home exercise programs so that the patient can return to the competition. And then impairments are also addressable by PT interventions. The only poor prognosticating factor would be her sport, which is cheerleading, would be hinges for her to be a candidate of excellent prognosis because it is highly susceptible for recurrence of injury. Long-term goal of the patient, rehabilitative. Patient will demonstrate cheerleading maneuvers as manifested by jumping, lifting, and dancing without pain and difficulty after 3 weeks of PT sessions. Preventive would be patient will verbalize importance and demonstrate proper execution of home exercise program after 1 week of PT session.
Lagersola for problem list and STGs. So for our problem list, our first problem would be proprioceptive deficits on the right lower extremity, followed by fair dynamic standing balance. Third is weakness on the right ankle as to plantar flexion, dorsiflexion, inversion, and eversion. Fourth is the pain, graded 5 out of 10, and swelling on right ankle. Fifth is LOM in all planes of the right ankle. We prioritize proprioception because this is the major factor that we look at to determine the possible recurrence of an ankle sprain. And according to the FA, the number of failures the patient had in 1 minute was significantly high, so which is why we put it as our topmost priority. This is followed by the fair dynamic standing balance. We want to address this because we want to prevent the recurrence of the ankle sprains. And third is the weakness, given that the strength of her lower extremity muscles is 3 plus. We want to increase the resistance that she can take to be able to perform her cheerleading maneuvers. And fourth is pain, and because this is her chief complaint, but it is we wouldn't consider it as our top because it's considerably tolerable at 5 out of 10. And last in our problem list is LOM because most of the limitations are due to pain except for inversion, and we want to address this mainly just to prevent any gait deviations, but although it is still in a functional range. So for our STG, our first is patient will demonstrate increase in proprioception on the right lower extremity as manifested by a decrease in failures from 10 to 3 in 1 minute on eyes open one leg stance after 1 week of PT sessions to be able to improve dynamic standing balance. B. Patient will demonstrate increase in proprioception on right lower extremity as manifested by a decrease in failures from 15 to 8 failures on eyes closed one leg stance after 1 week of PT sessions to be able to improve dynamic standing balance. Our second SDG is patient will demonstrate increase in dynamic standing balance from fair to good after 2 weeks of PT sessions to be able to perform cheerleading maneuvers. Third is patient will demonstrate increased strength on the right ankle as to dorsiflexion, plantarflexion, inversion, and eversion by 1 grade after 4 weeks of PT sessions to be able to perform cheerleading maneuvers. Fourth is patient will claim decrease in pain on outer aspect of the right foot from grade 5 out of 10 to 2 out of 10 after 1 week of PT sessions to be able to perform cheerleading maneuvers. Fifth is patient will demonstrate increase in range of motion of right ankle, plantarflexion, dorsiflexion, inversion, and eversion by 10 degrees after 1 week of PT session to be able to ambulate without gait deviations.
Mutok reporting the plan. So for the plan, it's important to note that the patient is in the subacute phase of healing with pain and swelling on the lateral aspect of the ankle. To address that, hot moist packs will be used for 20 minutes. Next, to maintain ROM and joint and muscle integrity, ROM will be used in all planes of the right ankle. Next, manual stabilization isometric exercises as tolerated will be used to maintain muscle strength, especially on the right peroneals and the gastrocsoleus. Next, for proprioception deficits, partial weight bearing balance board exercises with stirrup taping on the right ankle to provide support in inversion and eversion. The exercise is the single leg stance on the Bosu ball for 30 seconds with emphasis on the ankle to increase proprioception on the right ankle. Next, to address the dynamic standing balance exercises will be done in standing with moderate challenges. Next, for gait deviations, we will be doing gait training with emphasis on heel strike and mid stance on the right foot for 50 meters and 2 rounds to decrease difficulty in ambulation. After that, PREs with gold TheraBand towards right knee extension, flexion, and hip extension and flexion IR and ER to increase muscle strength of related joints. Aerobic training will also be done using the bicycle ergometer to maintain cardiovascular endurance. For the progression, when pain and swelling have subsided, we can progress the patient to return to function phase. So in the return to function phase, we will be doing GPS or gentle passive stretching, especially towards plantar flexion and dorsiflexion, also in evert and invert of the right ankle. For 15 seconds hold for 3 sets to increase ROM. We will also be doing PREs using the red TheraBand towards plantar flexion and dorsiflexion, invert and evert on the right ankle to increase muscle strength. We will also be progressing from partial weight bearing to full weight bearing on the balance board exercises, still without stirrup taping on right ankle to single leg stance using the Bosu ball for 1 minute with emphasis on the ankle again to increase perception on the right ankle. Next, dynamic standing balance as exercises will be progressed from moderate challenge to maximum challenge from 1 minute to 2 minutes to improve dynamic standing balance. Agility training will also be done to control twisting, turning, and lateral weight shifting to increase agility. Aerobic training will be progressed from bicycle ergometer to jogging for 20 minutes to increase cardiovascular endurance. Plyometric exercises will also be introduced using box jumps, especially to facilitate cheerleading maneuvers. And finally, functional exercises will be done simulating cheerleading maneuvers such as jumping, lifting, and dancing for 8 trials. For the HEP, at home when the patient is recovering, patient will be doing arm exercises on all planes of the right ankle within the pain-free range to maintain ROM and joint and muscle integrity again. Patient can also do towel crumpling exercises without or with weights on the right to maintain intrinsic muscle strength. Patient will also apply hot compress on anterolateral aspect of right ankle to decrease pain and swelling. Patient will also do full weight bearing single leg stance on both lower extremities times 1 minute to increase proprioception. For patient education, patient will be educated on precautions and complications of recurrent ankle sprains. Patient will also be educated on preventive measures for ankle sprains, like proprioception training and the like. Thank you.